So good morning. Pediatric ocular tumors are very rare, but vital to diagnose because they are going to be life-threatening. So most common intraocular malignant tumor is retinoblastoma. Then comes the medulla-epitheliomas. The leukemic infiltration is quite rare, but they are do common neuroepithelial tumors. Malignant appearing benign lesions are the retinocytomas, the amatomas, and hemangiomas. So the true masquerades, actually it looks like a persistent presentation is like a persistent fetal vasculature, but it turns to be a medulloepithelioma or a leiomyoma. And retinoblastoma, we know all those pseudogliomas, that leukocoria presentation. The most common mimicker is going to be Coats disease and also infective etiologies. So if you see the case one, it was a 7-month-old female child who referred as endogenous endophthalmitis. On examination, the child had circumcorneal congestion. There was a pinkish yellow globular mass on the iris at the fourth claw cover, and there were also few nodules on the iris surface. Both the corneal diameter and axial length was symmetrical in both the eyes. There was a retrolental fibrovascular membrane. So this mimics PFV, but ultrasound was normal. There was no evidence of any and ultrasound biomicroscopy showed a large ciliary body mass in the infratemporal quadrant with fibrosis, with iridocorneal adhesion, and with opacified lens. So the differential diagnosis was whether medulla epithelioma or is it juvenile xanthogranuloma. Excision biopsy was done, and we were able to see a lot of taut giant cells, and stroma showed infiltration of eosinophils and histiocytes suggestive of a juvenile xanthogranuloma. So this another case was a 9-year-old female child with good visual acuity, presented with a shallow AC in the right eye, and temporal part of the lens was opaque, and there was a fibrovascular tissue and a non-pigmented vascularized mass. The fundus showed temporal dragging of vessels, and as expected, the ultrasound biomicroscopy showed a hypoechoic lesion in the temporal quadrant, and MRI showed a ciliary body lesion. Excision biopsy was done, and we can see a mass with fibrovascular tissue with histopathological features suggestive of medulloepithelioma. Oncologist referral was done, and the PET CT showed no other metabolically active tissue. There's another case, a 2-year-old boy who presented with white reflex in the right eye. He had a pigmented vascularized mass the 8th to 10th clock hour, and there was a fibrovascular tissue attached to the PC, which was a retrolental fibrovascular tissue mimicking a persistent fetal vasculature. Ultrasound biomicroscopy showed a cystic lesions at the ciliary body area, and MRI also showed a ciliary body lesion. And referred as we planned for the excision biopsy, and we found there was no obvious mass, but there was a cyst lesion with the fibrovascular tissue which was excised, and histopathology showed neural differentiation in them, and it turned out to be a leiomyoma. So mimickers of advanced retinoblastoma, as Collins called it in 1892, any condition which resembles retinoblastoma is the pseudoglioma. So all this NDP-related retinopathies which present with a white reflex is one of DD for retinoblastoma. And this is a 7-month-old male child who presented with white reflex in the right eye at 3 months of age. It's more like xanthochoria. You can see it's more of an yellow reflex, and we can see some subretinal exudations. And ultrasound biomicroscopy show close funnel RD with subretinal echoes, but you can see a dense echo collected like looking like a mass. But this dynamic B scan will help us to see whether whether the echoes underlying are mobile or not. If it is mobile, then there is no mass underlying. So this dynamic B scan is very helpful in case of when you have such confusions. And the more typical of Coats disease is the telangiectatic vessels with light bulb aneurysms, which can be very clear in this picture. This child underwent a subretinal fluid drainage, and the fluid was sent for analysis, and there were no malignant cells. So if it's a unilateral child, if it's a male child with the first decade of presentation, you see telangiectatic vessels with aneurysms, and the dynamic B scan shows there is more mass, then you're dealing with the Coats disease and not retinoblastoma. So other mimickers, as I told you, cataract is obvious, their B scan will be normal. ROP and FEVR are more a temporal oriented disease, means you have a retrolental fibrovascular tissue, but it is mostly attached with the retinal fold, temporally oriented towards the lens. And persistent fetal vasculature is more the nasally oriented disease. And B scan will definitely help us, will say as there is no mass lesion. And dynamic B scan, as I told you, will be helpful to rule out Coats disease. There are pseudogliomas. Because of this ROP telescreening, we are picking earlier new retinoblastomas and other confusions. Like when we see a mass, we always very scared because we don't know how it is going to progress. So this was a child with screen for ROP, and we found a mass lesion at the posterior pole and another lesion. the mid periphery. It increases in size in day 7. So there was no calcification and there is no much vascularity. It's more looking infective lesion. And we asked pediatrician to rule out the systemic workup, do a rule out sepsis, and we asked them to start a systemic antibiotics also. And we referred to the base hospital. We did a biopsy, and actually there was no growth for identified, but we gave a broad spectrum antibiotic, and the lesion healed with scarring. So another patient and a screen in ROP, and we are for ROP telescreening was done, and we don't see any lesion. There is subtle lesion in visit 1. In visit 2, you see at the macula a slightly elevated lesion, and we suspected some mass lesion, and we referred to the base hospital. There was no vitritis. There was actually there was no evidence of any sepsis also, which was ruled out by the pediatrician. There was no calcification, and partly when we refer to the base hospital, we see partly scarring lesion. So we asked for torch titer also, because we have to think of chorioretinitis, other torch infections, and it turned out to be CMV retinitis positivity. And with the 4th visit, we can see almost like a scarred lesion. So when you see a small lesion sitting, and just with follow-up, with systemic workup also, because all patients in the neonatal period are immunocompromised. You don't expect any vitritis, which to suspect, which will clearly say if there is infection or not. And when there is no obvious when there is increase in size with your follow-up, but it scars, it's morely an infective lesion. Why I'm saying this is another patient with presentation of plainful blind eye in the left eye, and which mimics like a group E retinoblastoma, and another lesion at the posterior pole with the group A retinoblastoma. It was diagnosed as retinoblastoma. We enucleated the left eye as it was as a group E mass, which was also painful. And histopathology shows astrocytosis with chorioretinitis. There was no evidence of retinoblastoma. Retrospectively analyzed, there was epilepsy and ash leaf macules, and MRI also showed ependymomas in the brain, and the diagnosis turned to be a tuberous sclerosis. So this is another case with the previous case in our mind. The 3-month-old kid was referred by the pediatrician with history of seizures, and we saw these mass lesions sitting in the posterior pole. And since we are aware that we had some experience in the past, we thought it could be a tuberous sclerosis also, and we asked for the pediatrician to look for it, and there were hematomas in the brain, and diagnosis turned to be a tuberous sclerosis. So this is another interesting case. You see a lesion at the preterm child screened during ROP and found to have a mass lesion in the posterior pole. There is no vitritis, but there was a Venflon site infection. There was systemic sepsis for this child. So we thought more of an infective etiology only. But ultimately on day 15, we found there was some calcific specks in that developing in that child. So we did a genetic testing and found out the child to be having a mutation in the RB1 gene. And as there was no resolution with transpupillary thermotherapy alone, we started intravenous chemotherapy. So this is another case of it's just a 5-year-old boy bought by the parents with a complaint of squint. The younger brother was already diagnosed with bilateral retinoblastoma. So it's obvious, like you can see a mass lesion with cyst, with RP degeneration. All these go in favor of retinocytoma. And there is no change in the size of the child, almost following him for more than 2 years, and there is no change in the size. So that is retinocytoma. This is the fundus of the younger sibling. You can see there is group A lesion, B lesion, and group E in the left eye, which were good regression with chemotherapy. This is another such family. We're showing retinocytomas and scarring in the left eye. So these are the new pseudogliomas which I want to highlight on, that amartomas, infective lesions like endogenous endof or CMV retinitis or toxoplasmosis can mimic a early retinoblastomas. And even retinocytoma is a close mimicker of retinoblastoma, which is well known. So thank you.